Welcome back, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years. Today, talking about cervical myelopathy, which basically means a pinched spinal cord in the neck. We're going to talk about why this happens, what the symptoms are from a cervical myelopathy, what your options for treatment are, the surgical option for treatment, what to expect before, during, and after that surgery, and the risks. So let's get right to it. Cervical myelopathy, pinched spinal cord in the neck. So what are some causes of cervical myelopathy? Well, the most common cause is something called cervical spondylosis, which is basically degenerative disc disease of the cervical spine. I did an entire video on this that you can refer to if you want. But basically, degenerative disc disease of the cervical spine means the shock absorbers or discs in your neck are wearing out. And that's a natural process of aging. Everybody gets it. But when these discs wear out, your body will try and compensate for that by, for example, growing bone spurs to try and increase surface area, decrease movement. Ligaments will get thick, also in an attempt to decrease movement. Discs will start to bulge out from where they're supposed to be, which can crowd the spinal canal. And then joints in the neck can get loose because the shock absorber is not supporting things like it should. So all of these things, disc bulging, looseness of the bones in the neck, ligaments getting thick, bone spurs growing, all of these things can crowd the spinal canal and take up space where the spinal cord is supposed to be. Add into that some people are born with relatively small spinal canals, some people are born with relatively large spinal canals, most people are born with average spinal canals. But the issue is if your spinal canal is relatively small to begin with, it's not going to tolerate the changes that occur when your discs wear out. It's not going to tolerate the bone spurs and the ligaments thickening very much before your spinal cord starts to get pinched. So the size of the spinal canal can really make a determination on how young you are when you start to develop symptoms of cervical myelopathy. If you're lucky, your buildup of arthritis will happen slow enough, you were born with a big enough spinal canal that you'll be able to live out your entire natural life and never get a pinched spinal cord. But not everybody is so lucky. So if you're watching this video, you might not be one of those lucky ones. And the reason that these changes cause symptoms is that over time, the fibers that run through your cervical spinal cord start to get pinched or pushed on or pressurized by these changes of arthritis. And the theory is, or some studies have shown that more than 30% compromise of the spinal canal can lead to symptoms of myelopathy. In addition, there are blood vessels that run up and down the outside of the spinal cord, and if they're getting injured or pinched, you can get symptoms of spinal cord injury from lack of blood supply to the spinal cord. So one mechanism is just slow, progressive pinching of the spinal cord by decreasing space. Another mechanism is for example, big bone spurs growing on the front of the spinal canal, and every time you nod your head yes, or turn your head too fast one way or the other, your spinal cord kind of dings up against those bone spurs, injuring the nerves inside the spinal cord. And then the final mechanism is injury to the blood supply to the spinal cord. And these are kind of the basic causes of the most common reason for cervical myelopathy, which is this buildup of arthritis. Now, there are other things that can cause compression of the spinal cord, such as a large herniated disc, where a piece of the shock absorber escapes out of the space where it's supposed to be and pushes on the spinal cord. This would be more common in younger people than older people. And when this does happen, it typically occurs more off to the side of the spinal canal than the center. And that's why a herniated disc will typically cause a pinched nerve symptom, where you have pain, numbness, and tingling running down your arm and a lot of neck pain. It is possible, however, for a large herniated disc to not come out to the right or the left and come out right in the center of the spinal canal. And that would cause a spinal cord syndrome as opposed to a nerve root syndrome, or what we call cervical myelopathy as opposed to a cervical radiculopathy. Cervical myelopathy, pinched spinal cord; cervical radiculopathy, pinched nerve running down into the arm. So that's another possible reason. And then a third reason could be trauma, car accident, motorcycle crash, bar fight, a fall. All of these things can cause a disruption of the anatomy of the cervical spinal canal and cause pinching of the spinal cord, which would give you a cervical myelopathy. But those are much less common than just gradual, slow development of arthritic changes such as bone spurs and thickened ligaments. And then finally, there are some diseases or problems that can mimic cervical myelopathy or fool doctors into thinking you have a cervical myelopathy when in fact you don't. And those are things like ALS or Lou Gehrig's disease. Amyotrophic lateral sclerosis is the name of that disease. That can fool people into thinking you've got a pinched spinal cord in the neck when it has nothing to do with a pinched spinal cord. Multiple sclerosis can mimic cervical spinal cord myelopathy. B12 vitamin deficiencies, certain brain pathologies, and there are certain signs and symptoms and things that you can pick up on physical exam that can help you figure that out. In addition, if you get pictures of the cervical spine with an MRI, let's say, and it just doesn't look that pinched, that's a good sign that you need to start barking up a different tree and look at some of those other more rare reasons for symptoms that mimic cervical myelopathy. So those are pretty much the causes of a pinched spinal cord in the neck. Again, number one cause being a slow, gradual development of arthritic changes. So when it comes to symptoms from cervical myelopathy, one of the big differences is neck pain. Yes, there can be neck pain when you have a pinched spinal cord, but much less common than if you have a pinched nerve. So neck pain and arm pain for cervical radiculopathy, not quite as often neck pain for cervical myelopathy. So neck pain, not a big indication for cervical myelopathy. Numbness and tingling in the arms and legs are highly possible when your spinal cord's being pinched. This is due to compression of the sensory tracts in the spinal cord. Weakness is another big indication of cervical myelopathy, and this can be not just generalized weakness in the arms or legs, but coordination type problems from a specific compression of cerebellar tracts in the spinal cord. People with cervical myelopathy have a typical way of walking that's like sort of a clumsy way of walking, difficulty with coordination, inability to use the fine finger motions for dexterity. A common thing that I see is that it's if you ask a patient to open and close their hand, they can't do it very quickly. So very slow opening and closing of the hands. Bowel and bladder problems are not unusual for cervical myelopathy. Bladder typically more than bowel problems, and that's usually a problem with urinary urgency or not being able to hold the urine very well or for very long. Reflex changes. Typically you would see hyperreflexia, where your reflexes are super strong, as well as revealing primitive reflexes, which are reflexes that you'll see in infants and babies that as they develop, the inhibitory pathways of the brain develop and suppress those reflexes. Well, the inhibitory pathways of the brain have to travel through your cervical spinal cord to get to your hands and your feet. If those pathways are interrupted or damaged or upset, those reflexes will show up. And those are things like the Babinski reflex, the Hoffman's reflex, clonus in the ankles, and these are things that you can look up if you want, but basically it's something your doctor will do in the exam room, which if they see these reflexes, it'll give them a hint that you may have compression of your spinal cord in your neck. It is possible to get pain radiating into the arms due to parts of the spinal canal or spinal cord being upset, but that's much less common with a cervical myelopathy than a cervical radiculopathy. And then finally, you can get something called a Lermitz phenomena, and that is basically a sharp shooting pain running from your neck down to your low back that can occur with flexion or extension of the neck. And that is a pretty pathognomonic for cervical spondylitic disease causing myelopathy. So these kind of generalized symptoms are what you would see in someone with compression of their spinal cord in their neck. This is really very different from pinching a nerve in your neck that runs down your arm. So that is kind of what you'd look out for to be suspicious for a cervical myelopathy. Okay, so before we talk about why or how a patient kind of ends up in my office for cervical myelopathy, let's take a look at some diagrams. So if we look at these pictures on the left, the one on the very left here is a side view or sagittal view of the cervical spinal canal. And the second picture here is a down the barrel view or down the tube view or axial view of the spinal canal. So this yellowish cord is the spinal cord. These squares are the bones of the neck. The little cushions in between them are the discs. The pointy things back here are the spinous processes. And these are the little bumps we feel down the back of our neck. And this is an example of what a wide open spinal canal looks like. Nothing's being pinched from the front here. There are no bone spurs growing. There's no discs bulging out. The ligaments in the back here are not thickened. So this is a wide open spinal canal. And this second picture here shows, again, nothing being pinched on the spinal cord from the front or the back, wide open spinal canal. Let's now look over at this picture up here on the upper right. Here you can see the bones are starting to grow these bone spurs. The disc is bulging out here. The ligament here is thick. The ligament back here is thick. And all these things are causing a localized area of compression or pinching of the spinal cord right here. Above it, you don't see those bone spurs. Below it, you don't see them. And the spinal cord looks free as a bird. So this is a sagittal or from the side view of pinching of the spinal cord. Over here, top right, we see more of the same. Bone spurs, pinched spinal cord. Here is a cross-section or down the barrel view, axial view of the spinal canal. The purple area is the spinal canal, and here you see a relatively open spinal canal, and here you see various degrees of pinching. And then lastly, on the right down here in the bottom right, we see a cross-section of the spinal cord with the various pathways of nerves running through them. The green, the purple, the dark green, these are all specific spinal pathways that can affect coordination, bowel or bladder function, sensation, strength, etc. So depending on where it's compressed the most, you can get various types of symptoms of cervical myelopathy that we discussed already. So now let's take a look at some CAT scans, and these are specifically CT myelograms. That means that some dye was injected in the spinal fluid, and that will light up the area of the spinal canal around the spinal cord. So on this picture in the upper left, this dark band is the spinal cord. The white-gray stuff on both sides is the dye that was injected. These squares are the bones of the neck. And you can see the spinal cord edges have nice straight lines. There's nothing pushing into this dye column that looks like the spinal cord's being pinched. On the right, you see the axial or cross-section view of that same picture. This circle in the middle is a spinal cord that's free as a bird. The white stuff around it is the dye that was injected. The bright white stuff around that is the bones of the spinal canal. And you can see the spinal cord is nice and round and nothing is pushing on that spinal cord. If you then compare that to this picture on the bottom left, you can see again the spinal cord is this dark band going down the middle. The white stripe around it is the dye that was injected. And here you see where the arrow is, this big dark mass pushing on the spinal cord. This could be all a piece of disc that's squeezed out of the disc space here. It could be an infection, it could be a tumor, but it's some kind of space-occupying lesion that's pushing on this spinal cord. This picture on the bottom right is a cross-section view of the picture on the bottom left. And here you see the spinal cord looks very different than the spinal cord above it. Instead of looking like a nice round circle, it's kind of pancaked like this. The white stuff around it is the dye that was injected. And here you see this black stuff, which is, again, a piece of disc, infection, tumor, etc. Whatever it is, it's pushing on this spinal cord, likely causing symptoms of cervical myelopathy. So that's a CT myelogram. Let's just look at some plain CT scans that will show us the bone spurs. Okay, so these are just plain CT scans, no injection of dye in the spinal fluid. And what we see here, again, side views of the spinal canal. And these arrows are pointing to these big bone spurs growing on the bones, pushing into the space where the spinal cord lives, which is in here. You can't see the spinal cord as well because there was no dye injected, but you can see the bone spurs. Here's slightly more off to the side. The bone spurs are very prominent. And that's an example of slow-growing arthritic bone spurs compromising the spinal canal and the spinal cord area. Now let's turn our attention to MRI scans of the cervical spine. This picture on the left is, again, a side view of the cervical spine showing a wide open spinal canal and no pinching. This band coming down here is the spinal cord. The white color on both sides is the spinal fluid, and the squares are the bones, the stripes are the discs, and again, no pinching. Contrast that with the picture in the middle. You see the discs are worn out, pieces of discs are sticking out, bone spurs are growing, the ligaments are slightly thick back here. All of these arthritic changes are causing pinching of this spinal cord. If we move over to the far right, we can see similarly some disc bulging. But what's more important is here, the canal is very narrowed, but this white signal or stripe inside the spinal cord is evidence of spinal cord bruising from pinching. And this is called cervical myelomalacia. What's also interesting to see here is that the changes of arthritis buildup aren't as bad as what you see in this middle picture, but the tightness of the spinal canal seems worse. And that just goes to show the point we talked about earlier, which is this patient has a congenitally narrow spinal canal, meaning they were born with a relatively narrow spinal canal, which means they will tolerate changes of arthritis much less than someone who was born with this wide open spinal canal here. So even though the changes aren't as bad, the pinching is worse because they started out with a smaller spinal canal to begin with. So these are examples of MRIs with wide open normal spaces, pretty severe arthritis and spinal cord pinching, severe spinal cord pinching, and spinal cord bruising. And now to show just a couple of other reasons, as we mentioned earlier, for pinching of the spinal cord in the neck and symptoms and signs of cervical myelopathy. This picture on the left, again, an MRI, a side view, pretty severe pinching of the spinal cord. Most of that is coming from a herniated disc. This piece of disc squeezed out very centrally in the spinal canal, not more off to the left, not more off to the right. And that's cervical stenosis or pinching, causing cervical myelopathy, most likely from a herniated disc. Here's another case of a severely pinched cervical spinal cord, but in this case, it's mostly due to thickening of the ligament in the back here. So excessive movement in these areas will cause this ligament to compensate for that by getting thicker and thicker. And if it gets bad enough, it can severely pinch the spinal cord. So again, two other reasons, less common than just general arthritis, causing pinching of the cervical spinal cord and probably cervical myelopathy symptoms. And finally, the axial MRI views or cross sections or looking down the barrel of the gun type views. The circle in the middle here is the spinal cord. The white stuff around it is the spinal fluid. This circle up here is the disc. This V-shaped thing here is the bones in the back of the spine. And what we see is a wide open spinal canal, a circular spinal cord, no pinching. The second picture here, we do see a disc bulge here. We see some thickening of the ligament back here, this black stripe. And you see the spinal cord is not as round as it is on the picture on the left. This is an example of mild to moderate spinal stenosis or pinching. Unlikely that this patient has signs or symptoms of cervical myelopathy, but keep in mind, when they're getting this MRI, they're lying still in the machine. It's quite possible with certain movements of the neck, either flexion or extension, this could get tighter. This is a snapshot in time. It's not a dynamic image which shows motion. We don't know for sure if in certain positions this could be tighter. And then finally on the right here, this far right picture, we see much more significant stenosis, not a lot of space around the spinal canal or spinal cord. The spinal cord is relatively flattened or pancaked. And this is either a large bone spur or a piece of disc, but that's moderate to severe spinal stenosis or pinching or compression of the cervical spinal cord. And again, these are axial images of the cervical spine on an MRI. Okay, so how do patients typically present and end up in my office with cervical myelopathy? Usually what's going to happen is the patient's going to notice they don't have a lot of neck pain. They start to have trouble using a pencil or a pen, buttoning buttons in their shirt or jacket, opening jars, fine motion dexterity issues with their fingers and hands. They may notice that their walking is different, or their spouse or partner or parents or kids will notice, hey, you're walking kind of clumsily, or they're tripping a lot, or somebody accuses them of being drunk because they're not walking straight or normally. There may be trouble with being able to pee. So urinary urgency or a frequency where you have to pee a lot, or you can't hold it in, or you have trouble actually peeing. And these symptoms will typically happen gradually, and they may be just brought up sort of on the side when you're with your primary care doctor for your yearly checkup, or they could be severe or significant enough or bothering you enough that you make an appointment to see your doctor specifically for those things. But typically what will happen is your primary care doctor will listen to these symptoms and they're going to say, well, this sounds like a neurological problem, and you'll probably be sent to a neurologist. Now, there's a chance your primary care doctor may skip the neurologist and start working up these issues on their own, getting blood tests, getting x-rays of your neck, etc. But my guess is they're going to send you to a neurologist. And the neurologist is going to examine you, listen to your story, and if they see any of those hints that suggest you're pinching your spinal cord in your neck, they're going to get x-rays of your neck and then an MRI of your neck. Now, there's also a chance they may not think this is a cervical spine problem because you're not complaining of a lot of neck pain or arm pain or pain in general. And that does fool some neurologists or primary care doctors into thinking, oh, this is not a problem with the cervical spine. But as I said before, pain is often not a primary symptom in cervical myelopathy. Regardless, even if they start barking up the wrong tree, they're going to start to figure out eventually that, oh, it's not a B12 deficiency, it's not ALS, it's not MS, it's not anemia or giving generalized weakness, for example. So they rule out these other things, and they finally come to the conclusion this is probably pinching of the spinal cord in the neck, and they finally get those pictures, and they're going to show significant pinching in your cervical spine. Usually the MRI will show that. Once that happens, you're then going to get referred to either someone like me, a neurosurgeon, or an orthopedic spine surgeon. And that's typically how a patient gets to see me and the path that leads them to me. Sometimes that can be a very quick process where they get to me quickly, or sometimes it can be a very long process. And a lot of that depends on how subtle their symptoms are, how early on in the process they are, as well as how quickly the physician diagnosing them figures it out. But that's how a patient ends up landing in my office with a cervical myelopathy. So a little bit of change in venue for the remaining part of the video. And we were talking about how a patient with cervical myelopathy would get to my office. Well, once you're in my office, I examine you, I listen to your story about your symptoms, I confirm that you do have symptoms of a cervical myelopathy and you don't have any other reason for it. I confirm on your imaging that you've got compression of your cervical spinal cord, and now it's time to talk about your options. And you basically have three options. Option one, do nothing and put up with it. I typically don't recommend this for patients with cervical myelopathy because pinching of the spinal cord can be a serious matter, and unfortunately, like the brain, the spinal cord, if it's injured or damaged, it can be permanent. So if you're at the point of having trouble using your hands, walking, bowel or bladder symptoms, it's probably time to get this fixed, as opposed to waiting until your symptoms become permanent or risking that they get worse and permanent. So option 1, do nothing. Typically don't recommend that. Option 2 is to treat this with conservative therapies, which basically means anything but surgery. And those are things like anti-inflammatories, muscle relaxers, pain medications, physical therapy, heat, ice, massage, chiropractor, acupuncture, wearing a neck brace, traction, creams, rubs, patches, steroid pills, steroid shots. All of those things are wonderful. They can certainly make people with pain feel better, but unfortunately none of those things physically change anything in your body, and they will not unpinch your spinal cord. And some of those things that might involve manipulation of your neck could actually be worse for you. So typically conservative therapy I don't recommend for cervical myelopathy with evidence of spinal cord pinching on your imaging. And that leaves the third option, which is fix it. And that basically means surgery. So let's talk a little bit about the two options for surgery to treat symptoms of cervical myelopathy. So the reason there are two options to treat compression of the cervical spinal cord is because you can do this from the front or the back. Usually the surgery from the front is one of the best ways to unpinch the spinal cord caused by changes of degenerative arthritis building up in the neck, and that's because most of the pinching is coming from the front. It also means that when you go from the front, you can get to those problems before the spinal cord, so there's no manipulation of the spinal cord required in order to remove those things. I typically like to offer that kind of surgery when there's one or at the most two spots in the neck that need to be unpinched from the front. And I'm going to show you on one of the pictures you've already seen on how you would do that surgery from the front to remove the things that are pinching the spinal cord. Now the surgery from the back is typically decided to be done when there are multiple levels of pinching or multiple areas that require decompression. And instead of actually going after the bone spurs or the disc bulges or the ligaments that are thick in the front of the spinal cord, you just basically remove everything in the back of the spinal cord so the spinal cord's not sandwiched anymore. That's usually good, and I'll again show you a picture you've already seen, when multiple levels are tight and it's mostly coming from the fact that the patient has mild arthritic changes but a congenitally small spinal canal. If you're going to do it from the back, you got to make sure the patient is not what's called unstable, where things are moving around too much in the front, because if you take all the bones and ligaments off the back or part of the joints in the back of the spine, it can make the patient more unstable. So usually if I'm going to offer someone a surgery from the back of the spine to unpinch things, I will do flexion extension x-rays of the cervical spine to make sure they don't wiggle too much in there and risk creating more instability. If that is the case, they can still get the surgery from the back, but instead of just unpinching things, you also have to put in screws and rods to kind of fuse things together so they don't run the risk of becoming unstable. So I'm going to now show you some pictures of where you would go from the front, or what situation you would go from the front and what situation you would go from the back. Then I'll talk a little bit about the surgery where you go from the front and how it's done, the surgery where you go from the back and how it's done, and then some pictures of what that looks like after the surgery is done. Then we'll go over the risks, benefits of that surgery, what to expect before, during, and after, and then we are done. So let's take a look at why we would choose to go from the front to do a surgery to unpinch the spinal cord. So in this first picture, which you've seen before, you can see the spinal cord being pinched by the bone spurs and the disc bulging between these two bones. So most of the pinching is coming from the front here, which means if you come from the front to unpinch this, you'll get to all this stuff before the spinal cord. If you tried to unpinch this stuff coming from the back, the spinal cord would be in the way. Same thing here on this picture. Most of the pathology or problems are coming from the front of the spinal canal. So to do this surgery, you make an incision in the front of the neck. You can see the retractors here. This is what I'll talk about later, where you use to protect the structures like the trachea and the esophagus and the carotid artery and the jugular artery and things like that. Here you see a drawing of the front of the cervical spine and the discs and the bones. You can see a scalpel being used to remove the disc, the retractors in place. Here's a cross-section view of the cervical spine and the spinal canal, and this arrow is the direction you come from to remove this large piece of disc or any bone spurs in front here. And again, you're pulling all these things towards you during the surgery, so the spinal cord is not really being manipulated in order to do that. This is a picture of what it looks like after the surgery. You've got the disc space that you use to get to the spinal canal and unpinch it. You've got a little bone plug in here, either cadaver bone or a piece of your own bone, meaning the patient's bone, or some special products that are like a plastic type material that have a big hole in it that you can stuff things in that'll make these two bones eventually grow together, and then a little titanium plate and screws to secure everything down. And the goal is to keep these two bones still, to let these bones grow together solid over time so they don't move around anymore, and you can't grow bone spurs, or you wouldn't grow bone spurs anymore if these two bones aren't growing or aren't moving around. And then these are some x-rays from the front, from the side, of what it looks like after the surgery, where you go from the front to unpinch the spinal canal. And there's the plate and the screws. Those two dots are the markers in the spacer that were put in. And if you were going to do this at 2 levels, the plate would be longer. There'd be 6 screws instead of 4. And if you have to, you can actually remove this entire bone and make this entire space filled with a bone plug or something that sits inside there to create that space between these two bones. So the single level is called an anterior cervical discectomy and fusion. If you remove the entire bone, it's called a corpectomy. But this is when you're going through the front in order to get rid of all this pathology pinching the spinal cord. Now let's take a look at what it looks like for reasons why you would go from the back to unpinch the spinal cord. Okay, so here is some pictures of the cervical spine on the left and in the middle that would be a relatively good case to do the unpinching from the back. So here you can see that you've got 1, 2, 3, 4 levels that all look pretty bad from the front, causing pinching, but all these ligaments in the back are also causing pinching. So it'd be tough or less ideal to do 1, 2, 3, maybe 4 ACDFs from the front, or a 4-level corpectomy where you remove all these bones, as opposed to just removing everything in the back. This picture in the middle, you can again see that the degree of bone spurs and disc bulging from the front is just not very severe. Things actually don't look terrible from the back either, but they have a congenitally small spinal canal, and it's tight in multiple levels. This patient might be a good candidate for just unzipping everything from the back and removing the spinous processes, the lamina, and maybe the inside part of the joints. And to do that, you would just make an incision down the middle of the neck in the back of the neck, scrape the muscles off the bones, and then remove these spinous processes and lamina. So the spinous processes are the pointy things. The lamina are these broader bones coming out to the sides. These are the facet joints, and you may need to take a little bit of the inside of those. But you can see here where all the pressure on the back of the spine is now gone. The stuff in the front is still there. You're not going to try and take that out because the spinal cord is in the way, and you really don't want to manipulate the spinal cord in the cervical spine. And so all this stuff in the front would still be there, but there'd be plenty of space in the back. And that is what it would look like after a cervical laminectomy. And then let's take a quick peek at what a MRI would look like after this surgery. And finally here we have an MRI before and after, multiple levels of pinching, congenitally small spinal canal, not terrible in the back, you can see some thickening ligaments here. But here's what it looks like after the laminectomy. These spinous processes back here are gone, you don't see them over here. You can see this white stripe behind the spinal cord, which is spinal fluid. So this spinal cord looks dramatically unpinched compared to the picture over here. So this is a great example of how decompression can remove those tight spots of cervical spinal pinching and probably symptoms of myelopathy. So as far as what to expect before, during, and after the surgery, at least for my patients, basically you'd pick a day, you'd show up at the hospital, you'd meet the anesthesiologist, we'd bring you into the operating room, we'd put you to sleep. If we're doing the surgery from the back, we'd roll you over onto a special table and secure your head in a special clamp to keep it still. Do the surgery, which from the front or the back usually takes between 1 to 2 hours. You'd wake up in the recovery room. The surgery from the back will hurt more than the surgery from the front because when you go from the back, you have to scrape the muscles off of the bones in order to gain access to the spot you need to operate on. When you operate from the front, you're kind of going in between the muscles. After the surgery from the back, you tie those muscles back up together, so that hurts a little bit more than when you just go in between the muscles from the front. As I said, you'd wake up in the recovery room. Throat's going to be a little sore if we went from the front. Neck's going to be a little sore in the muscles in the back if you go from the back. You'd be in the recovery room probably 45 minutes letting the anesthesia wear off. You'd then go up to a regular room. I typically would keep patients in the hospital one night for this surgery. That first night you just take it easy. You're allowed out of bed to go to the bathroom, but that's about it. The next day, the nurses will change your dressing. The therapists will walk you in the hallways. I'll be in around lunchtime, check your incisions, ask you how you're feeling, and it's quite possible that after unpinching the spinal cord, you may notice some immediate improvement in symptoms. But for cervical myelopathy, it is possible that it could take a few weeks before you start to notice anything. If the damage is bad enough and you had permanent injury to the spinal cord tracts, it may take up to a year to see your full potential recovery, or it's quite possible that you do have some kind of permanent deficit. In that case, your surgeon will probably discuss with you that one of the primary reasons for unpinching the spinal cord is to keep things from getting worse, with no guarantee that your symptoms would actually get better than where they are at that moment. Even though the surgeon says that, most patients do notice improvement, usually within the first 30 days, and then a second stage of improvement over the following year. If everything looks good the day after surgery, you'd be sent home. Usually I'll tell my patients to take about a week to stay home, and that doesn't mean lie in bed all day, but just stay home. You're allowed up and down steps, watch TV, read a book, take a nap, play on the computer, stare out the window, watch the grass grow. About a week after the surgery, you can drive, but for 2 weeks, I basically would want you to be a slug. No pushing, pulling, reaching, lifting anything heavy, housework, yard work, walking the dog, taking the trash out, exercise, sports, home improvement projects, hang gliding, or skydiving. So basically 2 weeks of being a slug. If you had a desk job, I'd probably let you go back at 2 weeks. If you had some kind of manual labor job, I usually say 4 to 6 weeks. Then you'd be back in my office about 4 to 6 weeks later with an x-ray. If we went from the front, I'd make sure the plate and the screws look good. If everything looks good on the x-rays and you look good at 6 or 8 weeks after the surgery, from my perspective, you're off the hook. You've graduated. You don't have to come back. So whether you go from the front or the back, the risks of the surgery are the same. Basically, the same 3 risks for any surgery, which is infection, bleeding, and problems with anesthesia. All very low risks, but they're in the book, so we have to tell you about them. And that's why we get blood tests, EKGs, chest x-rays, sometimes clearance from your primary care doctor or a pulmonologist or a cardiologist. Basically make sure you're healthy enough to tolerate the surgery and the anesthesia, and that's for the first 3 risks. We also give antibiotics before the surgery, sometimes after, and then we do the surgery in a sterile operating room. That lowers the risk for infection, but even though we do all those things, there's still about a 1 or 2% chance of risk of infection. And then finally, there's some special risks to this surgery because it's near the spinal cord. And that basically involves injury to the spinal cord itself, which can cause weakness or paralysis. Again, knock on wood, very small risk, but it's in the book, so I have to tell you about it. And then finally, something called spinal fluid leak. The covering of those nerves not only keeps in the nerves, it keeps in spinal fluid. If you get a tear in that covering, that fluid can leak out and give you headaches. Typically, if that happens, it's relatively not, I wouldn't say easy, but lots of ways to fix that. You can put a little stitch in that covering to get it to seal up. You can put some glue on it. You can patch it. Lots of ways to fix that. Again, very small risk, especially for these surgeries in the cervical spine, but they're in the book, so I've got to tell you about them. And then finally, there are some special risks for the surgery when you go through the front. You basically make a little incision transversely this direction. We try to put them in one of the creases of the neck. I don't like to call them wrinkles, I call them creases. Go between the muscle and the trachea and the esophagus through a natural tissue plane down to the front of the cervical spine and then do the surgery. The risks of that approach are the esophagus is near that area, so there is a risk of injury to the esophagus that can be a serious risk. But again, very, very low chance. The important thing to minimize or avoid that risk is, number one, make sure you have a surgeon who has a lot of experience with that type of surgery. And then when you're doing the surgery, you have to make sure that the esophagus is definitely neatly tucked underneath the retractors so that they are protected by the retractors and not at risk for injury from instrumentation during the surgery. And those are the risks of the surgery. Again, all very, very low, but they're in the book, so we have to tell you about them. So I hope that video was helpful. We talked about cervical myelopathy, which is basically signs and symptoms of an injured cervical spinal cord from pinching or compression. We talked about what those symptoms are, why you get them, your options for treating them, the surgical options, what to expect before, during, and after that surgery, and the risks. If you have a cervical myelopathy, it is definitely something serious, but not the end of the world, especially if you get it taken care of early. So best of luck, and don't forget the most important thing, stay healthy.